morning, everyone, or good afternoon, whenever you're going to be viewing this PowerPoint. This is PowerPoint is on genetics, and I don't think you can really get away with talking about OB without talking about genetics. Genetics now is huge in our in today's society, especially in the medical profession. In fact, many schools of nursing and advanced degrees feel that genetics course should be in all actually nursing programs because of the new knowledge and the way medicine is going with individualized personalized medicine in the future. Genetics plays a huge role. For our course, we can't get away with it because there is so much genetic testing that is involved in prenatal and prenatal testing. In addition to that, it has a huge impact on our outcomes. Now, when we talk about nutrition and making good choices, those are things that we can personally do to improve our outcomes. But sometimes when it comes to genetics, we have the genetics that we have. And so therefore, decision-making is a little bit more complex. In addition to that, when we talk about genetics, really we're talking about ethical decision-making many times. Some of you have had previous courses on genetics, and some of your knowledge on genetics may be a little bit more limited. So basically, don't get too caught up in a lot of the major detail stuff I'll be talking about. I'm going to let you know what you need to know, but I need you to listen to this to get the gist of how important genetics is in medicine today, particularly in OB, and how the decision-making affects our patients. So just listen and relax, and don't get stressed out as we explore certain objectives when we talk about genetics, some of the benefits and assessments and interventions, recognize the importance of education, and also we're going to look at the ethical, legal, and social implications of the reproductive system considerations. And also always thinking about recent advances of genetics. So let's begin. In genetics, there's been lots of recent advances, which has actually changed the field of healthcare. There's currently expanded roles for nurses in genetics and genetics counseling, and there's various types of genetic testing. I can ask you as student nurses, have you ever performed genetic testing? Many of you would probably say no. But if you were in postpartum and you did the metabolic screening test where they pricked the baby's heel and they filled a bunch of spaces on a card for baby, that's all genetic testing. That's population-based genetic testing. Many, when you're pregnant, you may have had an AFP or other genetic testing as well. In fact, there's probably more than 2,000 types of genetic testing out there. So basically, testing and identification of commonly tested genetic disorders is actually required. We need to know that when we're talking about women's health nursing. We want to provide holistic centered care. We want to provide guidance to our families. Many questions are asked about genetic risks, so we need to know a little bit about the risk factors. And we also need to understand that families are dealing with very complex ethical, legal, and social issues that are associated with genetic testing. So basically what I'm saying is we as nurses need to have a minimal competency in both genetics and genomics. When we talk about it, because we're talking about some ethical and legal issues, we need to recognize our own attitudes and values related to genetics and genomic science. We need to provide families with credible and accurate information. Many times we facilitate referrals when necessary, but it's important to assess families' knowledge and perceptions and responses to genetic and genomic information. Many people, when they get pregnant, they don't really have an understanding of the risks. You may say, oh, well, with your genetic makeup, you have a 25% chance of. Many people don't even know what that means. They feel if they have one child that's infected, then that's their one, and they probably won't have another child with the same genetic disorder. So many families lack the knowledge needed to make decision making. So we develop a plan of care, and it's interesting. We want to assess their genetic information. So basically, one of the easiest and most least expensive things that we can do is have patients collect family history, at least a 3-generation family history that includes ethnicity information. That's a huge factor piece in what in what genetics plays for that family. In fact, they say that Thanksgiving Day is actually considered a day when we should ask our family members, well, what was from? Where was so die from? Because we get a lot of information from family members. A lot of family members don't talk about why somebody died, or they keep family secrets hidden in the closet. Oh, I didn't know Grandpa died of, syphilis or some other things. Many people keep it locked up. So it's good to ask, have families ask about what their genetic predispositions are. When we talk about genetics, for those of you who are not that familiar, we're just talking about the study of individual genes and their effect on relatively rare single gene disorders, whereas genomics is the study of all the genes in the human genome together. So genes are the basic physical units of inheritance that are passed on from parents to offspring, and genome is the entire set of genetic instructions. When asked what little girls are made of, I was hoping he would say sugar and spice. Some humor. The Human Genome Project the primary goal was produce a map of every gene that comprises the human genome. And basically it's estimated that 2,500 genes or more make up the human genome. This is invaluable in the identification of genes involved in disease. And when we think about that, if I ask you, how many of you guys know somebody who's suffering from Parkinson's or Alzheimer's or fibrosis or sickle cell anemia or even cancer? Most people will say yes, and those are all genetic based. And I think we as nurses, one of our main goals is, of course, prevention and health promotion, but it's also to alleviate suffering. And I would say most people that have come across people with these genetic diseases that cause a lot of suffering, we know in our hearts that in some way we want to do our best to decrease the amount of suffering. And so a lot of times that genetics plays that role in trying to find out ways to help people who are suffering. It involves many, and it impacts many disciplines, and of course, nursing is in there. What is gene therapy? And this is important for you to kind of recognize. Gene therapy basically to correct infected that are responsible for disease development. So basically, if you have a defective gene, what gene therapy does, it inserts a healthy copy of the defective gene into the somatic cells. And just a reminder of what a somatic cell is. It's any cell of the body except for the sperm and egg cells. This has been moved from preclinical to clinical studies for many diseases, from hemophilia and complex disorders like cancer. So there's a lot of research being done on inserting a healthy copy of the defective gene into the somatic cells as part of gene therapy to help these people with genetic disorder. Again, family history is the single most costly piece of genetic information. Currently, there's over 1,900 genetic tests available. Most of the genetic tests now being offered in clinical practice are tests for single gene disorders in patients with clinical symptoms or have a family history of genetic disease. Some of these genetic tests are prenatal tests, and we do identify the genetic status of a pregnancy at risk for a genetic condition. So we do a lot of genetic testing in our department. And a lot of that, we used to do a lot of invasive testing, and now they're so good. I went to the last conference, and we can get so much genetic information just by taking mom's blood. We can get genetic information on the baby as well, so we can identify any kind of genetic disorders early on in pregnancy. And also, when we talk about preconception care and prenatal care, we want to get a history on mom, even preconception, because if they have some kind of genetic history, that they have a possibility of transmitting that to their baby in a 50% chance, then those people need to sit down and be counseled to make sure that the risk is worth it for them, or to have options available for them when they get pregnant. Genetic testing is huge in OB. So we have current prenatal testing options. Again, we encourage people to be aware of their family history, and if needed, get preconception counseling. Some people choose to adopt because of their genetic history. They don't want to take any chances. But those that are pregnant, we can do so much with maternal serum screening. We can even detect if babies are going to be a boy or a girl or whatever. We get a lot of information. Fetal ultrasounds, particularly between 16 and 20 weeks, can identify a lot of genetic stuff, or even cleft lip and cleft pec can be identified through ultrasounds. Then there's the invasive procedures that we're seeing less of because of the new development in the maternal serum screening, but we're still going to talk about amniocentesis and chorionic villus sampling. Maternal serum screening is just a simple blood test. There's one that's out there that's an alpha fetal protein. And there's a difference between screening and determining. So if we're doing a screening like an alpha fetal protein, or some of the tests are screening, we're just seeing if they're at a higher risk. So there's some blood tests that can determine if a person is at a greater risk, and it's an alpha fetal protein, at a greater risk for a neural tube defect or chromosomal abnormalities such as Down syndrome, trisomy 18, and trisomy 13. If the screening shows that they're at an increased risk, they may opt for more detailed genetic screening, whether it's for labs, maybe an amniocentesis or chorionic villus, or ultrasounds. So a screening is different than an absolute test result. Fetal ultrasounds tell us a lot. We do fetal ultrasounds from the beginning. They can determine due date and stuff, but usually people get the big ultrasound between 16 and 20 weeks, and they look at all kinds of stuff. But some of the stuff we can determine is their fetal heart activity, gestational age, growth, anatomy, genetic disorders, anomalies, position, function, and just fetal well-being. So there's a lot we can determine with ultrasound, but sometimes it's not enough. Sometimes if the screening or the genetic history looks bad, and I'll say even if you're over 35, you're at risk for, chromosomal abnormalities. So sometimes the doctors will order an amniocentesis, and I will say that I'm seeing less and less because it's an invasive procedure, and I'm seeing more maternal serum screening. But to talk about amniocentesis, what they do is they actually stick a needle into mom's uterus, and they draw some amniotic fluid. And from the amniotic fluid, they can assess fetal cells and they can get all kinds of, answer all kinds of genetic concerns. When they do an amniocentesis, they always monitor it with an ultrasound to make sure that we don't poke the baby or the placenta or anything. The thing with an amniocentesis is that it's possible only after about 14 weeks gestation. People think no biggie, but think about this. Think about people who find out they're pregnant when they're maybe 6 weeks, and they're all excited and they get very attached to the pregnancy. And then at 14 weeks, they find out their baby has a fetal condition. Decision-making becomes a little bit harder then. So the earlier we find out, some of the decision-making that comes with genetic testing is a little bit easier the earlier it is in pregnancy. Because sometimes the decision-making is, well, Do you want to continue with the pregnancy or not? And if that is the decision making, we try to give them that information earlier on. Here's a picture of amniocentesis where they place the needle into the uterus and they actually pull out amniotic fluid. And it looks like it hurts a lot and it's quite invasive. It is an invasive procedure, but it's relatively safe. And really, we don't numb mom or anything. And it really doesn't hurt that much. It's just that fear, tension, pain cycle we talked about on week 1, where people get really freaked out about it. I've sat through many amniocentesis. And most women are just, I think the fear is worse than the actual poke. The chorionic villus sampling is another invasive procedure, but the thing is that it's used between 10 and 13 weeks so that we can get information, really particular information prior to the 14 weeks. What they do is they go in the same way with a needle and ultrasound, and they actually remove a small tissue specimen from the fetal portion of the placenta, which reflects the genetic makeup of the fetus. They can sometimes go transcervically, going to the cervix or the abdomen, just like in the amniocentesis, but use ultrasound. Again, both amniocentesis and the chorionic sampling are invasive, but relatively safe. Again, maybe in the future we won't even need to do these because we're better and better and better. We're becoming more sophisticated with our maternal serum screening. And here's a picture of a transcervical chorionic villus sampling. Now, before we go on to predictive testing, I'm going to tell you, it's like, okay, so I get some maternal serum screening, or I'm going for an amniocentesis or a chorionic villus screening. It sounds relatively easy, and it's not the test so much that it's the problem. It's what are you going to do with the results of the test that is really, really difficult for patients. And it causes a lot of mind games. And I can say this, as I had my last baby after 35 weeks gestation. And I didn't find out, right away. And then it was like the disbelief. And by the time I went to the doctor, and they suggested chorionic sampling. Well, by the time I figured out my insurance and everything else, that window for that was over, and they were asking for an amniocentesis. And I wasn't really sure, but I went ahead and did it. And I think it's because I remember, when you get pregnant and you're at risk for genetics, which you are if you're advanced maternal age, which is over 35, they set you down and they tell you, you're increased risk for, trisomy and, Down syndrome and all these other things. And you become very fearful. And I remember when they did that, and I went to a baseball game, and I remember seeing a Down syndrome kid. I went in the bathroom and I just cried. I was just like, oh my gosh. And then you go to the genetic counselor and they say, well, less than 2% chance or whatever it was. And I'm like thinking, you mean I have a 88% chance of having a healthy kid, but still at an increased risk, and it still puts fear in you. But I remember the amniocentesis, and I remember talking with my friend, and I was so like, should I go? Should I not? Should I just trust? And I remember when I got there, they put this baby up on an ultrasound, and I thought, oh my God, it doesn't matter. And I remember saying they had me all prepped, and I say, no, I don't want this. And I remember they still went ahead and did it. They did the amniocentesis, which didn't hurt or whatever. And yes, I said, at the time I said no, but I am glad that they did that because when I got the results and they were all good, it really put my mind at ease, and I was able to enjoy the pregnancy later. But what if I had been faced with a decision of what if there's something critically wrong with my baby? What do I do? What do I not do? And there are some people that find out their babies don't have kidney function and their baby will not survive once they're born. Well, then they're faced with a decision. Well, what do they do? Do they continue on with pregnancy and then deliver when the baby delivers and say hello and goodbye to the baby, or do they terminate the pregnancy now or whatever? It's so extremely mind-boggling to these patients. I cannot tell you enough that it's not the test, it's the decision-making around the testing that makes it so very difficult. So predictive testing is a little bit different, okay? It's used to clarify the genetic status of a symptomatic family member. I don't know if you guys are familiar with Huntington's disease, which is a neurodegenerative disorder. or some others. But Huntington disease, okay, I'll just tell you. Huntington's disease, I had when I was actually in nursing school and doing public health, I went into a home, and this teenager who was very young, probably 15, had just had a baby, and the family was very angry with her. And when I did a home visit, I noticed that there was an adult that was probably early 40s that was walking around the house, and he seemed like he had Alzheimer's and Parkinson's together. Well, it turned out he had Huntington's disease. And if anybody is familiar with that, it's a genetic disorder that pretty much, if you carry the gene, you have a 50% chance of passing it on. And the thing is you're totally fine until about 40 years of age, when then you have a decline in both mental and physical disabilities. And it's a very awful disease to watch somebody going through. So this family was watching this family member go through that, and they were angry at the teenager because they had a baby without her knowing whether she carried the gene and would pass that on to the baby. So it was very interesting to see that. But if somebody in the family knows that they might have that gene, then predictive testing, may be able to predict if that family member has it, so they can make decision making prior to even getting pregnant as well. Predispositional testing is a little bit different, and that testing is like somebody who has breast cancer is testing for the BRCA1 gene. And this is a little bit different, because if we think of like Angelina Jolie, for many of you who know her, she watched her mother die from breast cancer, and that must not have been easy. So knowing it ran in her family, she tested positive for the BRCA gene. Now, because you test positive for that does not necessarily mean you're going to get it, but it does mean that there is a risk. So basically, you have to take a chance. Well, should I just continue, monitoring closely and wait? Or should I actually do something more aggressive because I am at risk? And what she did was she actually ended up getting a double mastectomy. She ended up getting her hysterectomy and her tubes removed to decrease those risk factors. But then again, if we look at Angelina Jolie, at the same time, she probably had a great surgeon to, plastic surgeon and everything else. So when I say that, I say there must be some disparity also in genetic testing as well that we have to be aware of. And then there's the population-based screening, which I talked about, what we do in the hospital for the babies. It's the neonatal newborn screening. And it's that we do, and we test for PKU, galactosemia, and sickle cell disease. And every state mandates a different amount. And we have 30 plus, and you can always check the website if you're interested in which ones. But we're just checking. We want to make sure that we catch those genetic disorders early on in the infant for better outcomes. There's a lot of risks associated with genetic testing. Sometimes there's high false positives in the screening, which makes people worry, and then nothing happens. There's the anxiety. There's altered family relationships. If you had a blood test that showed that your baby had Downs, some people would say, what if the mom wanted to keep and the baby didn't, the dad didn't want to keep the baby? There's a lot of, altered family relationships in that. In addition to that, there's discrimination, against those. If they've decided not to keep the pregnancy, people look down on them. And again, if they decide to keep the baby, there's discrimination there too, and stigmatism. There's also the gap between the ability to test for and the ability to treat. For instance, I talked about, Huntington's disease. If we tested that teenager and she found out she was positive, there's nothing to treat her. She would just live the rest of her life knowing that when she got to be about age 40, she would get the disease and have the kind of same death that family member she watched had. And that's extremely nerve-wracking. Sometimes, there's some insurance benefits, and we're not seeing so much of that anymore for pre-existing conditions, but there is ethnic and socioeconomic disparity associated with genetic testing. There's also the ethical, legal, and social implications, because the main concern is what happens with this information you get. So we do the test and we give you the information. And now that's where the difficulty becomes. There's anxiety, there's discrimination. And then what is considered perfect? Because if you tell somebody who has a Down syndrome baby that their baby is not perfect, they would probably give you a little lecture, because they would say their baby is perfectly perfect in their imperfection. Okay, so what are we considering perfect? There are people living with diabetes type 1. Are we saying that that's not perfect? So there's a lot of anxiety. There's a lot of decision making. And then there's also they have to decide on, some people will decide to terminate, some people won't. But can you imagine the anxiety? Because I don't think anybody really wants to terminate. And so when they're forced with that decision, makes it very, very difficult on them. We know that there's patterns of genetic transmission. There's and that's just basically what we pass on to our offspring. There's the multifactorial inheritance result, and basically it's a genetic inheritance on different chromosomes. They're all acting together. But not only that, but there's also, with that multifactorial, there's also, the environment, factors on that. And then there's unifactorial inheritance, which is controlled by a single gene. So we're just going to talk a little bit about both. Basically, what we're doing is predicting the probability of the presence of an abnormal gene from the known occurrence of trait and known patterns of inheritance. We just want to know the probability. So we have a multifactorial inheritance. Basically, it's a combination of genetic and environmental factors. Well, let's look at cleft lip and cleft palate. We know that there is a genetic inheritance, but we also know that in some countries and other areas that there's environmental factors that increase on that. Congenital heart disease is the same. Neural tube defects, we know that there's a genetic predisposition, but we also know that, folic acid has a lot to do with that, which is an environmental factor. And so there's a lot of things that are contributing to that. Pyloric stenosis, and a lot of these conditions too can range from mild to severe. So it's a multifactorial inheritance. So let's think of spina bifida as a perfect example of that. We know that certain families have an increased risk for it, but we also know that folic acid and certain other things can prevent it. And I will say that I had a friend, we worked together in OB, and when she was 35 years old, she had 3 boys, and she found out she got pregnant again. And she was at first not too happy, but as many people who then get pregnant and they weren't expecting it kind of get excited about it. And then she found out it was a girl. Well, I'll never forget the day she went in for her big ultrasound. And when she went in, they found that she had spina bifida. And on that appointment, they sat her down and they talked to her. And I remember she came down, and I was working in triage, and she was in tears. They had told her that her baby had spina bifida. The baby probably wouldn't talk or wouldn't walk, would have problems with the bowels and bladder, and probably be in a wheelchair, and may have some, problems with cognitive abilities. And she was a mess. And so I remember some nurses came to her and patted her on her shoulder and said, "It's okay. I know you're Catholic, but you can still terminate." And then there was those that were Catholic or Christian or whatever denomination, but they went to her and said, "No, that you have to keep the baby." And she was in turmoil. I mean, she was hearing people telling her this and that and all these different, factors and everything else. Well, in the end, she decided to keep the baby. And she was a mess that whole pregnancy, let me tell you. And I happened to be with her on the day Lily was born. And it was a C-section. And they took her right away, and they did surgery and everything else. Well, let me tell you, I just went to see her, and yes, and when I went to see her, the last time I saw her was at a dance recital. Okay, so baby Lily's favorite activity is dancing. Okay, She can walk, she can talk, she has no problems with her bowels or her bladder, and she's doing fine in school. So we know that with genetic testing, we can get results, but we also know those people that said they got gloom and doom and it wasn't as bad as what they thought. And this information out there actually complicates decision making even more. There's patterns of unifactorial inheritance. There's autosomal dominant, recessive, X-linked recessive, and X-linked dominant. So the dominant one is basically, I'm just going to say this, is that there's a 50% chance of inheriting if one parent has a dominant gene defect. That's huge. One parent has it, and the rate of transmission is 50% with one affected parent. Okay? And a lot of people families don't understand. Yes, you have a baby with this disease, but every pregnancy there's a 50% chance. I don't know about if you guys are familiar with this, but neurofibromatosis is a progressive disorder of the nervous system that affects tumors to form on the nerves anywhere in the body, and that's a 50% inheritance. Huntington's disease, the one we just talked about, it has the same type of inheritance. Factor V Leiden-Marfan syndrome. Now, we talked a little bit about Huntington's disease, and I will say it's really real. I have a friend who has had a daughter the same age as mine, and we belonged to an organization where we did charity for different organizations with our daughters. And she was telling me how she loved her relationship she had with her daughter in high school, because when she was in high school, she had a terrible relationship with her mother. And what she found out later was that her mother actually was suffering through Huntington's disease, and she watched her mother die. Well, she also knew then, as an adult, that she had a 50% chance. And she debated whether to be tested or not, because she didn't know if she wanted to know that when she turned 40, she would have this disease or not. But when she decided to have children, she decided she wanted to know. And so she got tested and found out she was negative. And she also had a brother, and her brother said he didn't want to be tested. Well, she had just found out that her brother, who had turned 40, actually had been tested, and he was positive, and he didn't want to tell anybody, but he was now carrying the symptoms of it. So again, there's no cure for it. So deciding whether you want it, but again, if you are going to be having kids, you have a 50% chance, for, passing this on. Factor V Leiden is a pulmonary embolisms. And I had a student once that told me her story. She said her dad, who was actually a coach or whatever for U of A soccer team, very prominent there, wonderful human being and father for her. But anyway, he called and he was having some chest, and they told him to go into the hospital, and he waited a while. But anyway, he died from a pulmonary embolism. And it was extremely stressful for the whole family. He was quite young. And then what she found out is that she was put on the birth control pill, and she actually came up with a DVT, and they tested her for Factor V Leiden, where they found out that she was positive. And her father probably was too, and passed it on to her. But if her father had known, he could have had prophylactic care, or he would have been at the hospital a lot sooner and maybe not have died. Now, neurofibromatosis is a disorder of the nervous system. And if you guys, a lot of people maybe are familiar more with like the elephant man or whatever syndrome, but this is a picture of a severe case. Now, what happens with neurofibromatosis, which is 50% again, is that the babies are born with these cafe au lait spots. And then later on, they'll develop these. In every case, the severity is different. I had a friend in college, actually, who was actually a brother in the Catholic Church. And he left the church, and he ended up getting married. And I actually saw him when he delivered his firstborn. And I saw him when he had his kids young. Then I ran into him about 5 years ago, maybe, and I realized I didn't even know that he lived in the same neighborhood area that I lived in. When I saw him, and I, in my mind, with my poker face, was thinking, I didn't know you had neurofibromatosis. It wasn't as severe as this, but I could tell that he had it. And I didn't say anything, but then he proceeded to tell me his story. He said when he was young, he had a few of these spots on his chest, but nobody said anything. And he always thought they were birthmarks. And then they had his first son, and his first son had those markings, and they did genetic testing, and they found out that both were positive for neurofibromatosis. And later on, he developed, these, and there's no surgery or anything that they can do about it. But he said then his wife and him had to figure out what their next step was, because they had wanted a lot of children. Should they take the chance or not? And they decided to take the chance, which was 50-50, and they gave birth to a little girl without it. But again, decision making, what do you do with the information, is very difficult. Now, autosomal recessive is different than autosomal dominant because the risk of transfer is 25% with 2 carrier patients. Okay, so a 25% chance if both parents are carriers. And some of these are sickle cell anemia, cystic fibrosis, and Tay Sachs disease. So most of you have heard about at least sickle cell and cystic fibrosis and med-surg, and those are not easy conditions to handle, but I had a friend who lost her child as a teenager to cystic fibrosis, and she still suffers from losing her daughter. So most of you know about cystic fibrosis. Most of you know about sickle cell. But Tay Sachs, some of you aren't so familiar with, but some of you have had babies or been to the doctors. Sometimes they're in the questionnaire, they ask if you have any Jewish or French Canadian history. And the reason they ask that is because they're screening you, because it's very common in Jews and French Canadians. What Tay Sachs disease is a fatal genetic lipid storage disease. So basically, a baby will appear normal at birth, but by age 3 or 4, it's died. There's no that exists, and the nerve cells become distended with fatty material, which is a relentless deterioration of mental and physical abilities, including blindness, deafness, and inability to swallow. And here's a picture of that. So therefore, that's pretty brutal. So most people with Tay Sachs, we want to screen them so that then they can have decision making prior to getting pregnant, or be prepared for decision making once they are pregnant. X-linked dominant is very, very rare, so I'm not going to talk about too much. It has been identified with vitamin D resistant rickets and Rett syndrome, and the rate of transmission is 3% with each pregnancy, males and females, but I'm not going to spend too much time talking about that because we don't see too much of that. Then there's the X-linked recessive. So basically, that would be the rate of transmission with each pregnancy is 50% male offspring only. So only the mother is the carrier. Probably the most common that we hear about is hemophilia and color blindness. And even though hemophilia we can manage, think about thinking about knowing, you have to have blood transfusions, or knowing that just a simple fall can cause you to bleed and those types of things. It's hard to sometimes live with some of these things, even though we can manage. Color blindness, they're coming up with some cool glasses and other things for that as well. Again, the medical profession, we're always talking about health promotion and disease prevention, but also talking about easing pain and suffering. So we know there's common genetic disorders. You all should be familiar at this point with Down syndrome or trisomy 21. But the question we would ask, and the question we have to be careful with, because those that have a baby with Down syndrome will say their babies are perfectly perfect in perfection. And that's what makes genetic testing even more difficult. What is perfect? We also know that cancer can be genetic in origin, We know breast cancer is the most common cancer for women, which is the second most common cause of death. Colon cancer is the third leading cause of death in women. And cancer definitely has a genetic component as well. So basically, takeaway is genetic counseling is really important. It's really important for people to know history. We need information. We need to educate. We need to support them. They are provided by a team of professionals. Most families do want an estimate of that risk, and they want to understand what that risk actually means to them. We provide prenatal screening, testing. We provide neonatal genetic screening and testing. We also provide palliative care for infants with life-threatening genetic conditions and their families. We want to identify and care for individuals with genetic conditions and their families. So care of women during pregnant with genetic disorders is a huge part of what we do. We want to identify families in need of genetic counseling, provide emotional support, bring about an embarrassments, responses to testing, and to understand what people are feeling. They're feeling denial, anger, hostility, fear, embarrassment, grief, guilt, and self-blame. To understand that and be patient and provide them the support they need. And also to become aware of how these families are defining and managing their ethical, legal, and social issues within the family system. Some questions. If you're not familiar with the alpha fetoprotein test, you can look it up a little bit more in your book. But a 26-year-old multigravidas, 14 weeks pregnant, and is scheduled for an alpha fetoprotein test. She asks the nurse, "What does the alpha fetoprotein test indicate?" The nurse bases a response on the knowledge that this test can detect neural tube disorders, and it also can affect Down syndrome. This is a screening test, so if it did come back positive, they would want further testing. What is gene therapy? Gene therapy is basically inserting a healthy copy of a defective gene into the somatic cell, not a sperm egg cell. That's the end of the genetic, and some of you may be thinking, wow, that's a lot. Take a deep breath, relax, don't panic. I think it's important to have this lecture to bring out an awareness of all what pregnant women are going through regarding genetics and decision making and the tests that are out there and what tests they need and what they're feeling for and how society is looking on it and those types of things. We need to be aware of that. We also have to have some basis of knowledge on genetics and genomics. I will tell you this, though, is that I will guide you on, I'll probably have maybe one or two questions, but I'll guide you a little bit more in depth because there's so much on genetics. So I'll give you some guidance. So when we talk about genetics in lecture, I'll give you a little bit more. But again, I don't want you not to study or not to be aware of how big this is in medicine today. Have a great day.